Good day, friends, and a warm welcome to episode 46 of season 2, 4D. As we all know, 4D stands for detailed discussion and dialogue in diabetes, in Indian diabetes. Why do we need this detailed discussion and dialogue? Because diabetes has become endemic to our country. And who should do this discussion and dialogue? It's all of us who shoulder the responsibility of managing diabetes and ensuring well being in our fellow citizens. So let's welcome an expert who is known for his education, his experience, his expertise, and also you will realize his etiquette. He's an elegant specimen of a gentleman. Warm welcome to Dr. Rakesh Gupta. Warm welcome, sir.
Thank you, Sanjay, for a very kind words of introduction. And it's a pleasure to be next to you.
Sir, the pleasure is ours. Please allow us to introduce you. Dr. Gupta is a fellow of the Indian Academy of Clinical Medicine, and he's a senior consultant in the Internal Medicine Department at Indraprastha Apollo Hospitals, New Delhi. This is one of India's most prestigious colleges. He teaches DNB students for internal medicine, and he is also associated with the Apollo Outreach Clinic in Guwahati and Dibrugarh for the past 1.5 decades. A very astute clinician and a very sensitive, a very well-known teacher. We welcome Dr. Rakesh. So, Dr.
Thank you.
Rakesh, it's now 2024 is coming to an end. The International Diabetes Federation has announced diabetes and well-being as its theme for the next 3 years. What does the word well-being mean to you?
I think the well-being. I think what we have learned in our PSM books is not to be free from diseases, but also having a good mental well-being status. And I must say that nowadays the younger generation is finding it a big challenge to be mentally in good space per se, and be free from disease per se. And we should be more at ease and lead a good, healthy, and functional life to the best of our genetics and to the best of our phenotypes. I think that is what probably comes to my mind when you ask me what does the well-being of a person mean.
So, sir, is there a paradox of plenty? On one hand, we have more physicians now. We have better training in diabetes. We have better drugs and fixed dose combinations. So, ideally, it should have been a cakewalk, managing diabetes and ensuring well being. But at the same time, we have a greater number of people living with diabetes and feeling unsatisfied with their treatment of diabetes. Is that paradox there?
There is a paradox there, but there is one very important university which has come over last 20 years, and that is the WhatsApp university. And I think the ease of knowledge which has come so easy by just by a click of button, people feel that they can get the knowledge on the tip of their hand, and they can probably be as accomplished to tackle their problems as much as a doctor of 30 years or 40 years experiences. I think this is a mindset which has come into a lot of people. I think a typical scenario, Sanjay, is, I think, and you would agree with me, that you see a patient, you spend around 20 minutes, 30 minutes with a patient of diabetes. You write down a complete prescription, you discuss with him in detail lifestyle modification, etc. According with the medicines also. He goes back home, and there is this 18-year-old son or a 22-year-old daughter sitting in front of a computer, and she says, "Acha dikhana mujhe kya doctor ne kya likhi hai dawai." So they punch it in the computer, and they see the pros and cons and the side effects and all, which is available to everybody by the click of the button. And they think in that one page is everything written which they require, and probably the doctor didn't know it, and they have put that on their father or mother without thinking too much about it. And they sometimes trash it, or they rubbish it, or if nothing else, they sow the seeds of doubt in the mind of the patient. Because of that, the trust factor which has been there for generations has kind of gone for a toss, and so much so that kind of patients go physician shopping, and they go from point A to point B to point C. And the problem of plenty, as you said, there's a problem of plenty of doctors also. And because of that, and honestly speaking, doctors probably, they also think that he has come to me, let me write something different. They might write some other group of drug or the same group, etc. And because of that, things go around in circles and patient doesn't. So I tell my patients always that first find out the doctor you trust, and then go along with the doctor. Only then the things will be good. And always get your children and all with you next time, so that they know and you can talk face to face and discuss. So I think we all need to spend that 10-15 minutes extra to tell the patients. But ultimately, because of the ease of knowledge, I think that paradox stands where it is. A problem of plenty, but a problem of lack of trust, which has come in over a period of time, because of which the problems are more and more.
We have another issue with plenty, sir. So when people come into the OPD, it is said that when God blesses you, He blesses you without limits. But at the same time, if you're going to get metabolic disease, that also comes without limits. So, diabetes, obesity, cardiovascular disease, all of them seem to come together. Would you like to speak about this, sir, from your experience and from evidence, and how we can manage these things together?
The truth is that for last 20, 30 years, that terminology of syndrome X followed by metabolic syndrome, and then we are seeing that a person is kind of coming with a complete metabolic challenges. And diabetes is one end of the kind of challenge. Blood pressure is another end of the challenge. Dyslipidemia is another end of the challenge. Morbid obesity is another end of the challenge. And the problem of plenty, like you said, a lot of food which is available, and all kind of junk food and all kind of tasty food which is available everywhere. And whatever one might say, but Indian food has always been rich in kachoris and samosas and jalebis and pakoras. And let's not deny that. Let's face it in our face. Has been handed down the years. In gurudwaras, they give that halwa, which is kada prasad, which is so tasty. But it's full of oil. It leaves so much oil on the hand. It is kind of very, very sweet. And I think the glycemic index of that halwa would be really, really phenomenal. So just as an example, I'm saying really, because of all this plenty, a person who walks into the chamber generally has everything. Another thing which you must have noticed is nowadays, a patient who walks into any chamber, whether it's a primary level center or whether it's a tertiary level hospital, they walk in with reports already in hand. They already have got those 30 pages, 25 pages of reports, which they've got it done from any neighboring place. Nowadays, at least there is one thing which has become cheap over a period of time, which is the ease of reports. Someone comes home, takes a sample, वो घर बुलाते हैं सुबह 7-7:30 ब्रश कर रहे होते हैं, वो सैंपल ले जाता है, and then they have everything in front of them. And these reports also are accompanied with lot of information which is studied, copied from somewhere, put in, and they already have a made up of mind that okay, fine, I've got a pre-diabetes or a diabetic and my HbA1c is so much, or my cholesterol is there, or my vitamin D. So patients themselves feel that they're empowered to take decisions on their own. And so a typical patient who walks into our chamber is generally a combination of all that. Education should have kind of been tempered with the experience of the doctors and trust, but unfortunately, not in all cases. There are a few cases in which patients do trust and go along with us, and I think over a period of time the trust gets built up. But generally it starts from minus and then it comes to zero and then comes to plus. So nowadays the treatment is holistic. It is not about sugar control only. When I was a senior resident and I was in Safdarjung Hospital when I was doing the senior residency, I was attached to the diabetic clinic, and I'm talking about the year 91 to 94. That time I was a senior resident there after my post graduation, and we used to have a diabetic clinic. And the only two drugs which we used to have that time was Dionel and DBITD. DBITD was the cheaper, fenformin. Even metformin was not in government hospital. I'm talking about, and insulins were also two types only: plain insulin or lente insulin. और इन्हीं चार चीजों के बेसिस पे हमारा पूरा डायबिटिक क्लिनिक चलता था हफ्ते में 2 बार, in which people used to come from CGHS and free injections and all from 100 kilometers and all, वहां से लोग आते थे और इसी को हम शटल करते थे. We didn't have HbA1c also that time. We didn't have so many facilities also. So I think a whole era has passed by. We have come quite a long way from that zone. But now, like I said, with all the medicines that are disposal, not disposable, disposal. It's a shame that we are not still able to provide that ideal treatment which we want to provide to our patients. The drugs have become cheaper. The armamentarium has grown. I don't think so in any field in medicine. The armamentarium has increased as much as diabetes. I mean, पहले हमारे पास सिर्फ sulfonylurea और bigonide होते थे in early 90s. यही दो थे. Now we have 8 groups. I don't think so in any field groups have increased so much. Leave aside the individual members. Now we have all those alpha glucosidase inhibitors, and we have this SGLT2 inhibitors and DPP4 and thiazolidinediones. We have so many groups and meglitinides, which is really remarkable. And but like you said, with problem of plenty comes a problem of other things also. So a metabolic syndrome patient has to be seen in totality, and patient has to be treated. Another good advantage in a way when we look at the pros and cons is that India is a land of combinations. So we have fair amount of combinations. We have 2 drug combinations, 3 drug combinations. We are fairly liberal with combinations, and pill load has come down. So, I sometimes, if I have a patient who walks into my chamber with a HbA1c of say 8, and he's a drug naive patient, it becomes very easy for me to tell him that, okay, fine, I'm going to start you with one medicine. and probably I'll start him with a combination of SGLT2 and a DPP4 and a metformin or whatever, and none of the three cause hypoglycemia. And you're very, very much within your rights to kind of start 2 or 3 drugs if the patient's experience is good. The patient is happy, he's gone back with one drug, but you have given him a casata. You've given him a 3-in-1 kind of ice cream, really, as such. And that way, it's very advantageous for us to use this combination and pretty good. But I think we have to be sure about what we are giving, what are the side effects, where does the patient fit into it. And like I said, the trust builds up over a period of time. I think gray hairs help, and that is why the practice now is holistic. It is not only about maintaining sugar. It's also about maintaining blood pressure, dyslipidemia, and even now we are looking at obesity, which we are talking about today. The drugs which probably are helpful in obesity, and I think everybody is aware of the fact that these are challenges which are there. And I think urban society especially has got used to the fact that if you have diabetes, along with that will come hand in hand blood pressure and dyslipidemia and others also. It might be difficult to accept it initially, but when the reports are in front of you and they have a black and white situation, then they understand what's there, and prevention is better than cure, and that's the way to go forward.
So that is very insightful what we have learned from you. Would you like to put a structure to this, sir, and share your experiences and also evidence with the people? And we have doctors listening from across the world. If you could share your slide.
You're talking about obesity, which we are the topic today. I think as there are
Yes.
around 10 11 slides. So what we'll do is over next 10 12 minutes, let me go through the slides. They may look a little bit cluttered, but let's go through the slide. And after that, again, resume our personal experiences and talks, and let's see where we stand.
Okay.
This is a topic which has been decided for today. Body weight, which is a risk factor for diabetes and CVD. I think we all are well aware that body weight is a very important challenge per se, and there is no question about it. And generally, when we talk about diabetes, we are talking about type 2 diabetes. We know that type 1 diabetes, which is around 5% of the population, is a thin, lean diabetic patient. We are not talking about that because that is a specific thing which is requiring insulin and all. And 90% patients are generally 90% and above are type 2 diabetes, and that's what we are talking about. Now, you look at this slide and it says that 73% of the urban Indians are overweight, and almost half of the urban Indians are obese, which is a true factor. And I would go on to say probably more than that also. Maybe it's underreported, and sometimes we don't look at that. And the maximum risk age is shown as 28 to 38 years. So that is the time when you have a highest risk of weight gain, and both for men and women. And the average person goes from being healthy at 26 to obese at 36 years. And that is what has been shown over a period of time in various kind of studies. Now, obesity is a complex condition, which means increased subcutaneous and visceral adiposity. And you know that when we talk about obesity, we are talking about a BMI. And the BMI for patient, if it's more than 25, technically, is a patient who has got overweight. It's above 30, you call it mild obesity. Above 35, moderate obesity. About 40, morbid obesity. These are some subheadings, although there are difference of opinions also. The association with adipose dysfunction and insulin resistance also is there, which increases the risk of diabetes and cardiovascular disease. Everybody knows that diabetes is a story of insulin deficiency and insulin resistance. And in type 2 diabetes, probably the insulin resistance is more rampant initially. And later on, insulin deficiency also happens as beta cell failure goes on as we grow with age. And that also all leads to increase in the risk of diabetes and cardiovascular disease. So almost 75% of the Indians are overweight. And the prevalence of abdominal obesity was found to be 40% in women and 12% in men. I would go on to say that probably I don't agree with this figure. These are figures which have been taken from various studies. I would say that probably it's more than what is shown. And studies show that 5 to 6 out of 10 women between the age of 30 to 49 are abdominally obese. And the association of abdominal obesity in women is stronger with older age groups, urban residents, wealthier sections, and non-vegetarians. I think this is something which we all are well aware of, that if you have problem of plenty, as we were talking about, these problems are also associated with that. It is more rampant in elderly people because the metabolism is probably a bit slower, and as we grow with age. And affluence is also kind of comes with time. Initially, person is struggling to make a house, to gain his, kind of 2 meals of the day. But as we grow old, we have more money on our banks. You have probably more eating potential. Nowadays, the eating is much more as compared to before. The availability of everything is there. And definitely in urban residents, the availability is much more. The wealthier sections, of course, are they have everything available at the click of the button. And thanks to all these nowadays, those Zomatos and Swiggies and all, I think every child, every home, people are just ordering left, right, and center, and they're just standing outside all take-home delivery centers and delivering all kind of food all around. And non-vegetarian food, of course, is richer in fats and carbohydrates sometimes, especially the red meat and all that which comes with it. So the association of abdominal obesity is stronger in women in all these cases, and that's something which we probably all would agree with. Next slide, please. And Indians are generally at increased biological risk with CVD. We know that an Indian obese patient is different than an obese patient outside. We have a different kind of structure as compared to others. The medical problems, especially the diabetes, the hypertension, the heart diseases, generally are known to occur a decade earlier in Indian patients as compared to the people outside. Indians are known to have the highest cardiovascular diseases or cardiocoronary artery rates, basically. And the prevalence of coronary artery disease in Indians living in India is 21.4% for diabetics and 11% for non-diabetics. And the prevalence of coronary artery disease in rural part of the country is nearly half than that of the urban population. I think that is true because of the kind of lifestyle which probably are there between the two places. But also, I would say that maybe in rural population, a little bit of underreporting happens. And when we talk about the CVD epidemic, and you see this cluttered thing on the right side, when we talk about the CVD epidemic in Indians, the population level changes and increased biological risk. There's a complex interplay with that once diabetes comes in. And many major transitions happen over a period of time. You can have epidemiological population changes, demographic, environmental, socio-cultural, nutritional, economic. And with all that is associated the kind of food you eat, the kind of exercise you do, the kind of choices you have in life. Whereas if you have an increased biological risk, then early life influences come into the picture. And there are some inherent biological and genetic differences which are there amongst different races and different areas. And I think that is probably a point which we all are well aware of. These all figures have been taken from a 360-degree overview of a medical journal, Armed Forces India in 2020. Next slide, please. So diabetes in India is a very great big challenge. Basically, India is considered a diabetes capital, as we have talked ad nauseum over the last few years in every slideshow. Around 77 million people above the age of 18 years are suffering from type 2 diabetes. Nearly 25 million are pre-diabetic, which means they are at a high risk of developing diabetes in near future as well. And adults with diabetes have a 2 to 3-fold increased risk of heart attacks and strokes. So these are very worrisome figures, and these are figures which have been taken from WHO and various studies by various doctors across. And that particular study, which was IACMR India B17 trial, which showed and was published in Lancet also. So all these are figures which are not very palatable or not very nice to go by, but that's a truth which is staring in the face. India diabetes is an epidemic for all practical purposes. And when you combine it with all the risk factors which it brings it along with it, we are talking only about the heart and strokes here. But we know that a diabetic patient tends to have more chances of having retinopathy and eye changes. They can have gastroparesis, gastropathies, and nephropathy. The renal problems are also so rampant in diabetic patients. Almost half the patients who undergo kidney transplants are diabetic patients. Then you can have peripheral vascular disease, you can have neuropathy. So diabetes is a huge problem, and I think by and large we all have been sensitized to this fact that this problem is huge and it needs to be tackled head on, and we need to bring down the numbers, and by whatever ways we can add on to our own efforts and also to the efforts which are of the community and the government per se. Next slide, please. Sorry, go to the previous slide. Sorry. Let me go through a little bit on the right side also. You can see that in various parts of the country, the parameters are different, and different percentages are seen all over India. The red one, which is the bold one, are the areas which are showing more than 10% of diabetics, and you can see the most of the South India is covered by it. Fair amount of North India is also covered by it, and that is again doesn't make a good figure. And on the right side, you see the urban and the rural divide. and you can see the urban across India, basically the rampant more than 10% sugar patients are there. But in rural population, probably a little bit in the affluent Punjab, Haryana belt, and a little bit towards the Bengal side and a little bit towards the Kerala side. That is more there, more present as compared to the others. On the other hand, and if you see the chart on the lower part, almost more than 15% patients, and we are talking about pre-diabetes. The first one is diabetic, the lower one is pre-diabetic, and again pre-diabetes also you can see it's more common in all the central India, including Madhya Pradesh, Rajasthan, and Himachal Pradesh, Chandigarh, and the northern belt. And these are the patients who have more than 15% of the patients are pre-diabetic. And again, the urban and rural divide in this case is probably almost similar. There's not much of difference. Almost across both the central India and the northern India is showing a more rampant kind of prevalence of pre-diabetic patients also. So in India also there is a certain division per se, but by and large, the problem is across board, whole country, rural, urban, divide notwithstanding. Next slide, please. So ADA brings out every year various kind of guidelines, and they have been gradually telling us about the linking of obesity, diabetes, and cardiovascular disease. The relationships have been there, which have been studied amongst diabetes, obesity, and cardiovascular disease phenotypes. This was a UK Biobank cohort study in which a fair amount of population was there. The UK Biobank participation was almost 4,51,000 patients. Patients were compared in a population amongst those who had no diabetes, which was around 4,28,000 patients, and diabetic patients were around 22,000 patients. So these were studied amongst patients who had a normal BMI or a overweight BMI or a obese BMI. And in diabetic patients also the three categories were there: the normal BMI, the overweight BMI, and the obese BMI. And the incidence ratios, which were seen, adjusted incident rate ratios, and cardiovascular death for BMI diabetes category, all showed on the left side, which was more prevalent in the diabetes segment. If you look at the bar charts, and this was about the difference in cardiometabolic phenotypes by BMI class and diabetic status, in that also you see across various parameters. On the top left, we see the mean carotid intima thickness. On the lower side, we look at the left ventricular ejection fraction, and you can see that the diabetes segment is showing more as compared to the non-diabetic segment. You can see the bars on the right side are more than the bars on the left side. And similarly, when you look at the pulse wave arterial stiffness index, which is on the right upper side, also is more there in the diabetic segment. And also the CCI, which is the other word for cardiac contractility index, that also is more rampant on the patient side, which is diabetic. So diabetes patients show an increased link of all the parameters which probably are directly linked with cardiovascular disease, really, as such. Next slide, please. And this was a study published in 2023. So there have been various mechanisms which have been proposed linking the obesity, diabetes, and CVD. The mechanisms for insulin resistance have also been proposed. Basically, adipose tissue and releases adenopokines, leading to inflammation. At the end of the day, diabetes is a vasculitis. Vasculitis is basically an inflammation thing. And there's a free fatty acids which goes to lead to impaired oxidative capacities. There's a mitochondrial function dysfunction which is involved. And all these are aggravating factors which include the excess lipid intake, inactivity, immobilization, aging, and chronic diseases, leading to accumulation of lipid derivatives, leading to lipotoxicity, and ultimately all leading to defect in translation pathways, leading from the insulin resistance path, and leading to decrease in protein quantity and quality. So these are the mechanisms which have been proposed for linking all this. And the linking of mechanism of insulin resistance leading to diabetes and CVD. Basically, insulin resistance leads to hyperinsulinemia, leading to increased MAP kinase activation, and that leads to accelerated atherosclerosis. On the other hand, there is an impaired P13 kinase signaling, leading to impaired muscle glucose uptake and impaired suppression of glucose production, and that leads to development of type 2 diabetes. So these are mechanisms which have been proposed many years. I think we don't go too much into the biochemical side. We are probably clinicians and we look more at the endpoints, but there is a method to the whole thing, and the linking between the obesity, diabetes, and CVD has been proposed by various mechanisms which have come over a period of time. Next slide, please. So, how do you go on to treat these patients? Now, the honest truth is that basically your idea is to generally kind of nip it in the bud. And I think you would do the best as a physician or a clinician, the best effort should be to kind of go for prevention. If you can prevent the patient from progressing to pre-diabetes to diabetes, your job is done. And I think that's a way to go forward. Once a patient has already come onto the diabetes stage, then of course you go with medicines and lifestyle and all that. But if you can prevent that, and if there's awareness which is more, probably that is the way to go forward. And that is what we all should concentrate on. And I think a better part of our every consultation should be more involved with trying to prevent that. Because I think everybody agrees that once a patient has become diabetic, and when he comes to you, say, and he's been showing you for many years or decades rather for some of us, in a 20 minutes consultation, probably the disease, you will talk about the medicines only for 5 minutes, because you just need to tinker or taper a few medicines here or there. The 15 minutes would be more devoted, kind of devoted to that continuous thing about lifestyle modification, walking, exercising, losing weight, cutting down on the fat intake, cutting down on the carbs. And I think that is the way probably our practice is built over a period of time. And that is what we are doing all the time. So, how can you try to kind of prevent the conditions? For obesity, of course, limit the unhealthy food, increase the physical activity, limit the television time, screen time, and other times, and improve the sleep and reducing stress. These are common sense things, but they need to be reinforced at every visit. And if your patient has to be prevented from going from pre-diabetes to type 2 diabetes, then lifestyle changes are extremely important. Reach and keep a healthy body weight. Start physically active with at least 30 minutes of moderate exercise each day, and eat a healthy diet and avoid sugar and saturated fat, and avoid the tobacco and smoking, which goes without saying. And if you have to prevent for cardiovascular disease, again, eat a healthy diet, increase the physical activity, stop smoking, know your blood pressure, know your lipids, know your sugars. And I think these are the factors which we try to reinforce from to patients again and again. And I think quite a few have printed on our prescription pads also about all these parameters. And we tick it whenever the patient comes, or fill it, and probably we fill it by nurses outside or whatever. And ultimately, it has to be ongoing kind of sensitization to the patient. Of course, medicines are there, but ultimately, prevention is the key to controlling it in the community per se. Next slide, please. Now, of course, the drugs and everything, as a clinician, we are always excited about the drugs. Unfortunately, most of the drugs which come to our country, we generally look forward to FDA kind of approving them. And they have had a roster of drugs which they have used for weight management. These have been updated from 2021. For short-term use, phentermine and diethylpropion are used, which I don't think so most of us use in our country anymore. And Orlistat also came with a lot. For long-term use, Orlistat was one drug which came with a lot of promise, but I think that has also fallen by the wayside. Phentermine, topiramate, we don't use it much. Bupropion, naltrexone, again, in some patients we use it, but not very many. Liraglutide, I think, again came with a lot of promise, and I think we have been using it. But again, it's an injectable, it's an expensive drug. So somehow it has not cut much ice. Gelesis 100, setmelanotide, these are approved, but we don't have access to these drugs. And semaglutide, which has made so much noise over a period of time over the last 2 years. From personal experience point of view, one must understand that semaglutide 2.5 milligram, 2.4 milligram injection, which comes by the commercial name of Ozempic, that is the one which has been approved for weight loss in US FDA, not the oral semaglutide, which is also available in US. But in India, we have only oral semaglutide, and because of the noise level and eagerness of a lot of patients, patients have started using these drugs for weight loss, irrespective of the fact that they may be diabetic or not. And as clinicians, and since in India drugs are available over the counter, people use it per se without bothering too much about the side effect and all. But I think we as a clinician should be very clear in our mind that in which cases semaglutide has a role to play. It's a GLP-1 analog. But like I said, in India, it's available only in an oral form, and we have 3 strengths, 3 milligram, 7 milligram, 14 milligram. So it should be judiciously used in our country as well. And then you have these anti-hyperglycemic agents also. And now a lot of noise level, and we have also become very careful about which anti-hyperglycemic agents to offer to our patients for weight loss. And we're talking about weight loss strategies. Now, if in generally, if you look at each drug which we have over a period of time, metformin, which is a biogonide, is generally considered weight neutral. Thiazolidinediones, of which pioglitazone is the major molecule, is generally may cause a little bit of weight gain because it has a tendency towards fluid retention in some patients. And insulin is the third one, which causes weight gain. And sulfonylurea, which we have been used for so many years, is known to cause weight gain. But apart from that, the DPP4 inhibitor category, the SGLT2 inhibitors, and GLP-1 analogs, all three are known to cause weight loss. And that is why these drugs have gradually got into our, and not only weight loss, they have very many other pleiotropic effects also. And that is why a clinician has become greedy now. We look at the cardiac benefits, we look at the renal benefits, we look at the benefits as far as the congestive heart failure are concerned. We look at the, now we know that SGLT2 inhibitors have become one of the four pillars of using in a patient who comes with congestive heart failure, in spite of whether the patient is diabetic or not, still it is one of the pillars. So now cardiologists have started calling it a cardiology drug rather than a drug for used for from a point of view of diabetes. DPP4 inhibitors are generally weight neutral drugs. Sitagliptin, saxagliptin, linagliptin, alogliptin is not available in our country. The SGLT2 inhibitors, canagliflozin, dapagliflozin, empagliflozin, we have been using it for donkey years. And GLP-1 analogs, which are glucagon-like peptide-1 receptor agonist that regulate and restore the incretin functions, are something which are also approved. This was from 2021. I think more drugs have come into the picture. Now we have a combination of GLP-1 analog and GIP, and I think next year probably we're going to have those. They have also shown tremendous results. Tirzepatide is one such molecule. It has shown benefit, and apart from cardiac, although basically it is the oral hypoglycemic, but it has shown a fair amount of evidence to show benefit in weight loss and all. I think we are going to hear a lot about them in coming years. And they have also been approved by FDA for weight management, and amongst anti-hyperglycemic agents, they are the ones which are used more popularly nowadays. Next slide, please. This has become a very major question nowadays, is heart failure. And nowadays we talk about heart failure with reduced ejection fraction or preserved ejection fraction. Like I said, the guideline directed medical therapy as for heart failure has shown that SGLT2 inhibitors is one of the pillar. Canagliflozin somehow has kind of lost midway, not being promoted very actively. So dapagliflozin 10 milligram and empagliflozin 10 or 25 milligram as per your choice have become popular. The advantages are now there in even HFpEF with preserved ejection fraction, reduced ejection fraction, and mid ejection fraction also. So the use of SGLT2 inhibitors has shown improvement in diastolic dysfunction in patients with HFrEF or heart failure patients and reduced oxidative stress. It is known to show to decrease the inflammation, fibrosis, and myofilament stiffness also when compared with the patients who are not using SGLT2 inhibitor. Next slide, please. So there are very many studies, and there are evidences-based studies. And this was one study which was published in 2015. This was a 24-week international multi-center randomized double-blind parallel group placebo-controlled phase 3B study in which they looked at HbA1c and fasting glucose with dapagliflozin, showed very significant results. More patients achieved a therapeutic response. And it also showed that the body weight and the systolic blood pressure was also reasonably reduced, especially with dapagliflozin as one of the prototypes of SGLT2 inhibitor. Next slide, please. So in practice, amongst other drugs, various combinations we have with us, and almost every two or three drugs have been combined. One such combination, which is SGLT2 inhibitor and DB4 inhibitor, it comes with different mechanisms of actions. Both have different mechanisms, and the advantages are very many. And main advantage is that both improve the insulin resistance and functioning of beta cells. They are safe, rapid, and sustained glycemic control. They aid in body weight and blood pressure reduction also, although it might be just 2 to 3 millimeter of mercury. And more patient compliant, of course, because when you give a combination, it's better. It reduces the pill burden as well. It is cost effective also. And there's another advantage which is not mentioned here, which I must put it, that generally speaking, the SGLT2 inhibitor is associated with genitourinary infections. But when you give a combination of drugs with DPP4, studies have shown that the genitourinary infections also somewhat decreased with the combinations because of various mechanisms which are inbuilt. So the combination is popular. We have been using it, And this is one of the other drugs, amongst other drugs in our momentarium, which are useful in patients who have diabetes along with obesity issues. And maybe he can give his own opinion also. Dr. Kalra, you are such a renowned endocrinologist. What we have talked about and what are the slides shown. Let's hear your opinion about the matter also.
A great presentation. Actually, Dr. Gupta, I am reminded of an episode from the Mahabharata, and this we call the Jarasandh syndrome. So, Jarasandh was the king of Magad, and he was born as two lifeless lumps, two equal halves, and then they were put together by Jara, an Asuri. So, when Bhim was trying to kill him, there was a battle going on. Lord Krishna signaled to Bhim, uh, break the leaf into half, tear a leaf into half. But what he would do is Bhim would tear Jarasandh into half, and then Jarasandh would get combined again. So it seemed to be a kind of a battle which he would never be able to win. What Lord Krishna signaled then was, you tear the leaf into half and uh, throw both halves in opposite ends. That is what Bhim did, and finally he was able to vanquish Jarasandh. Let's look at diabetes and obesity. There are times when we try to manage diabetes, but we end up increasing adiposity. There are other times when we try to manage diabetes, obesity. We have done that in the past and we have burnt our fingers, and we end up increasing other complications like maybe suicidal thoughts and tendencies. So, if we were to view diabetes and obesity together, or diabetes and cardiovascular disease together as one Jarasandh, as Jarasandh syndrome, what do you think that fault line would be? Where should we focus? If we were to focus on one thing, how can we vanquish Jarasandh?
It is not surprising that these episodes of Mahabharata are coming from you, knowing that you have a practice in Karnal, which is right next to Kurukshetra, which was
Yes.
a which is a battleground for Mahabharata, as we all know, really, etc. But thanks for enlightening us on this episode of Jarasan, and definitely it is an allegory which goes down very well. I think the question is very simple, and I think we have all this. This is a chicken and egg kind of story, basically. Should we tackle obesity and obesity comes down and patients' sugars also come down? Or should we tackle diabetes and the diabetes comes down and probably the insulin resistance comes down to some extent and patients' obesity comes down? So I don't think so any of us can answer this question. I think we actually have to tackle all a patient in totality. You can't say that I'm just tackling this part or that part, and I think you know that very well. So I think nowadays a patient also knows that this complete metabolic picture is the one which probably has to be treated in totality. And that is why a typical patient goes back with, generally, most of the patients go back with oral hypoglycemic drugs, along with antihypertensives, along with cholesterol medicines, along with kind of aspirin or primary prevention or secondary prevention, whatever. But yes, obesity, lifestyle, all that has to go hand in hand. And I think, in as much as we kind of keep on talking about it, how much of patients follow it, how much they come back with us with better results, I think your guess is as good as mine. And it is a frustrating kind of scenario, because although so much noise level is there on nets, and so much media is also involved with it, but on the other hand, you see the turn the page and you'll see the awards being given to restaurants, and you'll see all the kind of food which is being labeled and being put forward. So I think we are living in a society in which choices are there, and I think whatever we might say, patients are the ones who make the ultimate choice. The approach has to be totally patient centric. This is one thing which we have learned over 10 years, to 15 years, I would say. Previously, we used to impose upon them that, okay, these are the best medicine, you take it and let's see how it. Now we have to sit down with the patient. We have to see what his desire is, what he's looking at, what are the targets in his case, how much of drug do we need, does he really need a drug which will probably cause weight loss also. There are patients, and I'm sure you have in your practice also, who come back to us and say, डॉक्टर साहब आपने वो दवाई शुरू की थी, वो उससे हमारा तो लोग कह रहे हैं इतने कमजोर हो गए, आपका इतना वेट लॉस हो गया, and they don't take it very well also. Some of the
Yeah.
people, or some ladies especially, कि हमारा पति तो इतना लोग कह रहे हैं ये हो गया वो गया. Anyway, we are happy in our hearts, and maybe that's just a fringe benefit, or this is just a spillover effect. But some people take it the other way around also, especially in northern India. So I think it is completely a one-to-one approach with the patient. I think I would devote, first time a patient comes to the clinic, 30 to 40 minutes, sit down with him, look at all his kind of home conditions, see what are the medicines he can get. Even affordability is a thing. You might say that I want to use a GLP-1 analog, it's shown very good results, But if a patient can't afford it beyond 2 3 months, what's the point giving it? So I think in India, every point is sensitive, and I think as a clinician, you have to see what best you can offer to the patient according to his needs, and no point going overboard. And one shoe does not fit all. And I think that is how I would tackle a patient. Obesity, hypertension, diabetes, cholesterol, heart, these all are subsets and parts of that. I would call them all Navratan of the. I think Deep Franzo should have been given that term near Navratan to all these people. And I think that is the way to go forward, really, as such. And I think we all are moving towards that kind of practice now.
That's nice. It's reassuring to from such a senior physician to see this sense of optimism and reassurance. We can put things together. We have improved, and we need to keep on working. Of course, we see the disconnect between public awareness and public action. But then that again is what Jarasan stands for. He stands for an enemy that is difficult to vanquish. Then you need Bhim, that is the strength, the brute strength, the brawn of Bhim, and also the brain of Lord Krishna to work to fight the enemy. And I guess that is what we need in the OPD. We need to know our stuff, we need to know our science, but then we need that astuteness, that sixth sense to be able to handle the patient properly from a psychological and social perspective. What Dr. Gupta spoke about people not liking weight loss, that is what we call the Sarpanch syndrome in Haryana, because the patient comes and says, I want to gain weight, otherwise nobody respects me in my village. Then we use Haryanvi common sense to answer that. We use the concept of kabaddi. So for those of you who are fond of playing in boxing and in wrestling, in judo, in taekwondo, you have different weight categories. We learned that the hard way in Paris when one of our athletes lost out on a medal. But in kabaddi, you have only one weight category. You have to be below 85 kg if you want to fight in as a male in kabaddi, and you have to be below 75 kg if you want to play as a lady, as a female athlete. So we mention this, and then they understand, yes, there must be common sense, there must be good sense in this. So that's a rough weight above which I should not go. So these are ways in which we can sort of engage our community in a meaningful discussion. But Dr. Gupta, I'd like to thank you a lot. So much of insight and expertise from what you have said, and I'm sure everyone across the country would have benefited. To everyone who is logged in with us, thank you for being part of 4D. We are coming to the end of season 2, but we'll continue. And there's always something new, something exciting, something wonderful just around the corner, just around the next week. Thank you, everyone, and Jai Hind.
Thank you, Dr. Kalra, and thank you to everybody who's tuned in. Have a nice festive season. Thank